Well, hello. All right, we still got a couple minutes while people join us. How's everybody today? Good. Good. Don't forget to sign in and chat. Good, I see everybody doing so. If you'll notice, the inflammation part 2 video is up. So it went up about 9:30 last night. So don't get thrown by seeing other students' faces at the very beginning. One of them was driving. I don't know what happened when I started the recording, but there it was. And I do come on and teach after that. So don't get thrown by that. So this is my last class with you until after fall break, and I do comfort. So comfort you're gonna listen to, and then beforehand, and then we're gonna do a short case study for class period so you can apply it. Okay, by that time you'll be fully head on into applying things. You'll have some clinical time in which you've been applying interventions and critically thinking and stuff like that. So some of y'all have gone through case studies already, but you know, you'll be ready for this. And comfort is one of those touchy-feely kind of subjects, you know, so fluff your aura, fluff, you know. Oh, nobody's in the mood. So there you go, Michelle.
So, Miss Leaf, this will be recorded and posted as well?
Yes, but it probably won't be posted till next week because you're not going to watch it anyway.
No, you're right.
So, you know, it takes me a while. It took me all yesterday to get it to convert to an MP4 and then to get it, you know, into YouTube and stuff. I mean, it's no big deal, but it takes a while. And so my main concern was to get you that second part of the inflammation up and get that done. So I think today I'm going to get ready for my clinical groups. And so I have 2 of them. So today, that's what I'm going to do instead of sitting by the computer for 4 hours and watching things convert. For 5 hours, whatever it was. Zoom had to convert it, then YouTube had to convert it, then it had to convert it again. So yeah. Anyway. So, all right. So as people keep joining us, we'll plug along. You guys, you know, this is a continuation of inflammation, because this is what happens when inflammation gets worse, right? The bacteria invades or some kind of microorganism or virus or something invades, and there becomes an infection. And so all those inflammatory responses and all those signs and symptoms get worse. You know, the redness, the edema, the pain, the loss of function or impaired function. You know, what am I missing? Redness, edema, pain. Y'all help me out. Anyway,
XJ,
Edema.
induration.
impaired
Correct.
function, heat, thank you. Heat, impaired or loss of function, all of that gets worse, and the exudate starts turning purulent, right? And so whether it's coughing up mucus and it's a creepy color and it's, you know, got an oil, you know, all those different characteristics. I'm not a mucus person. Give me changing poop all day long and you know, throwing up doesn't bother me. Any kind of GI bleed doesn't bother me. Blood doesn't bother me, but give me a good hot loogie and I'm done for, you know, kind of. It's like you put on the face and you just go, okay. So, you know, we all have our things. We all have our things. So for infection, what I want to share with you first is a study that was compiled in late 2019 before COVID, and about healthcare associated infections. And it ranges between 28 billion and 45 billion in annual direct hospital costs in the US alone. Y'all don't have to write this down. I want you to just think of how phenomenal this is.
Say that
In
again.
a bad way. Huh?
Can you say that one more time?
Hospital associated infections, between 28 billion and 45 billion in annual direct hospital costs in the US alone. Okay? You don't have to write, I'm not testing you on this. So, but I want you to be aware, because this is what we do, is infection control. And this is what happens when we don't pay attention to doing things as we should, and why they make care bundles for these specific things so that we can circumvent these kinds of hospital-associated infections that can harm patients, and we don't want to you know, create further injury for them. So the hospital-acquired infection is CLABSI. What is CLABSI? Central line associated bloodstream infection. Okay, sounds pretty serious, right? That's bacteria in the bloodstream. It's going to attack any organ that it sees. Okay, the estimated deaths per year is 28,000. Additional cost per patient is $48,000. Okay, a CAUTI, C-A-U-T-I, is what?
Catheter associated.
Urinary tract infection, bullseye. Okay, so estimated deaths per year is 13,000 with an additional cost per patient of $13,800. And then VAP, you know, VAP is probably not even on your radar, but that's ventilator associated pneumonia. Okay, estimated deaths per year, 36,000 with an additional cost per patient of $40,000. Okay, so this is nothing to play with. People are dying because we're not washing our hands effectively, or we're not changing the dressing to the central line when it's got, you know, when it's loose somewhere, or we're not utilizing sterile technique when we should by suctioning the patient, by inserting a catheter or leaving the catheter in, or not cleaning the urinary catheter as well as we should be. And then, so those are all very important things. So basically, what we're talking about is, you know, infection. It's worsening of inflammation. And there's a complication called sepsis, which is basically a severe reaction to infection. Okay, it's not an exemplar, but I can test you on a worsening infection. Okay, so sepsis is a severe reaction to infection. It happens when the bacteria does get into the bloodstream from some other source, or from the central line, but it can come from urinary tract infection in anywhere and start attacking other areas of the body. And what happens is these microorganisms produce toxins, and they cause septicemia, infection of other, or inflammation of other body organs, and cause them to lose function. Okay. And then they can go into shock with this, called septic shock. Reason why I'm bringing this up, and you do have a handout in the infection tab, recognizing and managing sepsis, okay, is you guys don't actually learn about sepsis, septic shock until your 4th semester, the end of your 4th semester. I want you to start being able to recognize this semester and next semester and into your 4th semester if your patients end up going down this road, okay, because you can save a life. You can literally save a life. I have a cousin that was plowing snow on a Friday and dead by Sunday afternoon. Okay, because of sepsis. There's also a nursing student, a graduate, that graduated, had a baby. She's come, I'm not divulging anything that, she hasn't divulged before. A year later, after the baby, she wanted a IUD implanted. She went on a Friday after work, had an IUD implanted. By Friday night, she was just feeling tired and kind of malaise, and thought it was just from the day and everything. And then Saturday morning, she started running a fever and still not feeling well. And as the day progressed, she's like, I need to go to the hospital. By Sunday, she was on a vent and she was fighting for her life. She went into septic shock meaning very low blood pressure, and it's not perfusing the body. So what happens when the body goes into shock? What does...
Shut down.
Your blood starts shunting to your vital organs.
There you go. And the vital organs being?
The heart and the brain.
Heart, brain, and lungs, right? Right here, this top half. Screw the kidneys, it's this. And then, of course, hands and feet, you can forget about it. So in order to keep even this functioning and the blood pressure up enough to keep the vital organs, okay, up and perfused, they have to be on vasopressors or potent blood pressure vasoconstrictors, okay, that help keep that blood pressure raised. Well, if you're talking vasoconstrictors, what's going to vasoconstrict first? You're already telling me the blood shunting through vasoconstriction up to those core areas. So these meds are going to even force the vasoconstriction more, and keep that perfusion going to those vital organs. So what's going to happen to the periphery? Their fingers, their toes.
Gonna get cold and
They're going to
pale.
turn black. They're going to turn black. And this graduate did survive, okay? She lost one arm up to the elbow. She lost most of the fingers on her other hand, and she lost both legs up to the knee due to the vasoconstriction and trying to save her life from septic shock, okay? And what I want to try and prevent is you recognizing the initial onsets of sepsis so they don't go into septic shock, okay? And so that's why I'm telling you this, the worsening side of things. So if you're looking at this sheet from Lippincott Nursing Center, the Recognizing and Managing Sepsis, the thing that you can do is on the second page, and it's called the Quick SOFA score, SOFA, okay? And it provides a simple bedside criteria to quickly identify adult patients with suspected infection who are likely to have poor outcomes or become septic, okay? So the criteria are respiratory rate greater than or equal to 22 per minute. Now that's for a normal adult, which is high, right? It's on the high side, right? Normal's upward of 20. But who goes up into 22 or so? What's
Elderly.
it? Elderly. Okay. So what you're talking about when you're looking at your patient clinically, you're looking at the trends of their vital signs. What are their normal vital signs run? Where is their heart rate? Where are their blood pressures? You know, what's their usual temperature and stuff? And what's their usual respiratory rate? So if their usual respiratory rate is 22, possibly 24, then, you know, that may not be the case. You're going to have to go higher than that if their respirations increase to more than that, okay? Altered mental status. And we know that with elderly, that's an automatic given with infection, but we need to be even more careful and hone our assessments with them with this. But for regular normal adults, you know, change in level of consciousness, hypoxia, something's going on. So we need to make sure that we're watching, you know, increased ammonia from hepatitis, whatever, that we're finding the cause, you know, we need the solution, we need to take action and prioritize those. And the big thing is we want to keep that systolic blood pressure greater than 70. So anytime you see a systolic blood pressure less than or equal to 100, it should be suspect unless that's their norm. Okay, and then you're going to be looking a little bit less, but we want to keep, it's the mean arterial pressure, I'm sorry, greater than or equal to 70. Okay, some of your teachers may say 60, whatever, depending on the, this is my source and this is what they use for the American Journal of Medicine.
You said greater than 70?
A MAP, a mean arterial pressure. Did y'all learn how to do that
Yeah.
in assessment?
Yes.
So what is
Yeah.
it?
Systolic minus diastolic
No,
pressure.
two,
Systolic pressure
Just-
plus 2 times
Oh, it's
diastolic
the-
divided by 3.
diastolic times 2
Pulse pressure.
plus systolic divided by 3. So if you have a pressure of 84/50, okay, diastolic times 2 is going to be what?
100.
100. Good.
100.
Okay. Plus you're going to then add the 84, the systolic, gives you 184. Divided by 3 is going to give you 60. Okay. So we have to watch that perfusion. That's not good. We need to figure out what's going on here. Okay, so we may have to ramp up some fluids, but then we have to listen to their lungs and elsewhere to make sure they're not third spacing from the sepsis. So there's a lot going on and you need to really hone in on assessments and you need to know your patients very well. But, you know, the signs are when that pressure starts dropping, how's your heart going to respond?
Beat that.
Usually.
Faster.
It's going to beat faster to compensate, right? And then when your heart quits compensating, that's when you know they're circling the drain and the blood pressure goes lower. Okay? So let's go with what you were asked. Infection, you know about this in the chain of infection, okay? You know about the inflammatory response and that it's normal until it's not. If it's not, you know, healing within a few days, then it's looking to be infected. And so locally, everything would get worse. Systemically, what would we see? Come on, you guys.
Fever,
Yes.
Increased pulse.
Fever, increased pulse,
Good.
respiration, malaise, anorexia, nausea, vomiting.
And increased white blood cells, right?
yeah.
You know, so we're monitoring the lab, so increased white blood cells. And we're gonna watch for the elderly because they may not have the telltale 101 fever. It may be lower, why?
Because their regular is lower.
Right, so then that's where that change in level of consciousness or confusion comes in for the elderly as one of the first signs of infection. Okay, so I've said my piece with that. Oh, and multi-drug resistant organisms, MDRO, you might see that. You know, MRSA, methicillin resistant Staph aureus, isn't just that anymore. They have vancomycin resistant Staph aureus because MRSA, vanc was used to treat it, and now it is acclimated and you need something else. VRE, vancomycin resistant enterococcus, and the list goes on. How do you make sure that bacteria does not acclimate itself or you know, come back and you need something stronger?
Finish your full prescription of antibiotics.
Absolutely. How many of y'all start feeling better? You don't want to go to the doctor. I see some heads dropping. And so as you feel better, you say, oh, I'm just going to save the rest of this prescription for when I get this again. And you put it up in the cabinet. And then when you take it the next time, it doesn't work. Well, it doesn't work because you made that bacteria smart and now you need something stronger in order to eradicate it. Okay? You know, and people are famous for keeping it up there, and then somebody gets cellulitis or something, and, oh, I've got antibiotics at my house. They're only 10 years old, you know, and it's ampicillin or something that, you know, may not even be a drop in the hat next to the infection that they have, and they can't understand why it's not working. Okay, so a lot of teaching there, a lot of teaching. So let's start out though with TB, speaking of teaching. Okay. So TB is a chronic recurrent infectious disease caused by Mycobacterium tuberculosis. Now, TB is everywhere. It's everywhere. The people that get it are specific in that their immune response is not maybe what it should be, or they have close proximity exposure over time. Okay, it's a public health issue, so it needs to be reported and it needs to be tracked. This is nothing new in this day and age, COVID, right? Nothing new. Okay, so there are drug-resistant strains of TB, and a lot of that comes from those people that do not finish the course of therapy and they're reinfected or they still have the disease, and when they put them back on the medication, it doesn't work, so they have to add other kinds of meds, anti-tubercular meds or just antibiotics to fight the condition. Okay, how they diagnose it? is they come in, okay, and they feel kind of flu-like, okay? All those flu-like symptoms, the malaise, everything that they described. More than not, they get that low grade or fever in the afternoon. They have weight loss and loss of appetite. They can have a dry cough or a purulent cough or that has blood in it, which is hemoptysis, okay? Decreased breath sounds. One of the big telltale signs is night sweats, okay? Night sweats. So they can have trouble breathing, you know, and may not have that much trouble breathing. But usually if they're coming in, they felt like this for several days and they're whipped, they have an elevated temperature, they're breathing a little fast, they've got diminished breath sounds, okay? They go get them a chest x-ray or CAT scan, and what they see on that is these little tubercles, okay? Which is the body's way of fighting this infection by walling it off into these little tubercles, these little calcified circle things on the x-ray. And it's a telltale sign. And so they will diagnose it from there. Before it used to be, oh, you have to have 3 confirmed cultures before you can actually diagnose it. Not anymore. Too many people were getting exposed. Okay, so between that and if they can cough up some sputum and they do an acid fast test for the bacilli, then they can confirm it those 2 ways until they can get an actual sputum culture. And that may be they take some of the sputum that they have for a culture and smear it on a slide, and that's their first culture. But it takes 3 weeks for a culture to grow out, and you're not going to hold them and not treat them for 3 weeks, you know? So we're going to treat them. Now, the very, very first thing, and this is, see what you know, what is the very first intervention you're going to do?
Based on precautions.
Isolation in a negative pressure room.
There you go. Airborne precautions, negative pressure room. Absolutely. Just like COVID. Okay. Nowadays, this is not so out of the mainstream like it used to be, because since March, we've seen it all too often and fast and furious. Okay. So negative pressure room, which means that it is ventilated through a HEPA filter out into the atmosphere 6 to 10 times an hour, okay? And so it does not circulate within the hospital itself. It is ventilated out, okay? And so negative pressure room, you'll have an ante-room before the negative pressure room where you don your PPE, which includes what kind of mask, which we're not, unfortunately.
N95.
Yes. Okay. It has to be fit tested in the hospital, okay? Meaning to make sure there's a fit to your face. Nowadays with Corona and the lack of PPE, that's like humorous. You know, they can't even do that anymore. It is what it is that you can cover your face, okay? And so the big thing is that when you get a call from ER of a suspected TB case, you got to make sure you have a negative pressure room if you're charged or, you know, on the unit that's available. Because if you don't have one, you can't take that patient, okay? So when you're going into, you know, as that patient, let's go back, is coming up from the ER, you need to tell them to hold till you can get the room ready, and that you will call them when they can send the patient up. Patient's gonna come up with what?
Surgical mask.
Surgical mask. So everybody's going to be wearing the surgical mask. This isn't this isn't new time nowadays, but surgical mask. But you want them to be able to go straight into the room. Nobody ambulating in the hall for PT on the walker. No IV poles, vital signs machines in the way. You want them to be able to get them straight away, because if for some reason they feel like I can't breathe, they take off the mask. You want minimal exposure to people around. Okay? Once you get them in there and you've got your N95, you put on whatever else PPE you need to take care of that patient. You don't need hair cover, you don't need foot covers, okay? But you probably need a gown, you know, face shield, gloves, especially if they're just coughing and they're not, you know, coughing into their elbow, or they don't have tissue yet or whatever to cough into. You need to get them set up, boxes of Kleenex and their own little trash bag, like in the bed or tied next to the bed, so they can put their Kleenexes in there and not try and throw them across the room in the trash can or what have you. Okay, and you certainly don't want to be picking them up off the floor.
Will they need
Okay.
goggles as well with the
Well, a
mask,
face
gown,
shield would be fine, or goggles, so whatever.
Testing purposes, are you gonna have specific things that we're gonna have to know, or is it not gonna be that detailed for infection? Does that make sense for like the PPE? Because like last semester, it was very specific.
Well, you need to know how to put it on and how to take it off,
Well,
and
yeah,
what you would need.
what we're gonna need though, because I feel like last semester they didn't really say to have the gowns. It was mainly just an N95 mask.
But it depends on what you're doing for the patient. If there's a chance for spilling, or if, you know, if you got a, you know, you're emptying a urinal or something like that, that could splash, or they're coughing without, you know, if it says that they're coughing and they're not covering their mouth or whatever, then that could come on you, you know, so you want to make sure. Now, difference is TB doesn't last on a surface as long as COVID does, you know? So nowadays, but, you know, it depends on what the circumstances are, what you're doing for the patient as to the PPE you're gonna need. And that's with any patient nowadays, because you're gonna need a mask for any patient, and then additional PPE is necessary. Okay. And so airborne precautions is the very first thing, okay? Very first thing. Make sure that you cluster your care so that you're not going in and out. But in that time too, yes, it's gonna be hot in that PPE, and then the patients are gonna feel like you wanna bust your butt to do what you need to do and get the hell out of there. Okay, well, you know, now you're gonna have to do this for everybody, so you're gonna have to get used to it, being COVID, but you're not gonna have TV and COVID patients for clinical. But just so you know, they're gonna feel isolated because they can't get up and walk around necessarily. You know, they need to be in the room. There's only so much Hallmark Channel and Young and the Restless that they can watch. So they're going to get bored easily and not have much mental stimulation. So have the family involved, bringing them books or crossword puzzles or something that keeps them active and that they have a variety of things to do. Remember, they're only going to see this much of you. So however you can communicate with your eyes and even with touch to let them know that you care and that you are there for them is extremely important, because TB was seen as dirty, as bad, because you were isolating them. Well, here we go with COVID, and it's everybody and their mother. So, you know, the stigma isn't there like it used to be, okay? So complications, you know, they can get abscesses and it can develop into pneumonia and pneumothorax. So you want to make sure what kind of focused assessment, thorough focused assessment are you going to do on these patients?
Lungs.
Lung and thorax.
Respiratory, absolutely. Respiratory includes O2 sats, right? Okay, so priority interventions are going to be, number one is going to be airborne precautions, because you need to get them into the room and where they're going to be. And then if they look in distress, you know, you hook them up to some oxygen. You're going to see where their pulse ox is, you know, all those kinds of things for them in priority. And we talked about the ABC for study skills and test taking techniques. Okay, so you're going to do all those kinds of general things that we discussed about monitoring INO and those kinds of things. You want them to keep hydrated so they can start to expectorate this stuff up, you know, from their lung and away. You might see blood tinge. You might see the hemoptysis coming up from the destructive force of this bacteria, because it does destroy the lung tissue and leaves a fibrotic kind of change there that can make those capillaries and things very brittle. And so a forceful coughing, continued coughing, can cause them to cough up blood. Okay, so we talked about the diagnostics tests, the CAT scan or chest x-ray. We'll get a sputum culture. But the acid-fast bacilli is going to be another way to diagnose. Now, what's a way to prevent getting TB from the get-go? Does anybody know?
Is there
The
a
washing?
vaccine?
Okay, well, let's go with who can get this disease? Who's specifically
The homeless.
Compromised.
Yeah.
good? Okay, those incarcerated or living in some kind of mental health facility in close proximity, homeless in those camps, even several families living crowdedly in a house. Okay, it's in the air. The minute somebody gets immunocompromised and there's close physical contact continuously, somebody can get TB. Okay, and they don't have to be immunocompromised. It's just that it could be a significant other that you're just very close to, and you talk together and you know, and stuff, and it's continuous exposure. Okay, but a lot of times it is a number of things: HIV, AIDS patients, immunocompromised, autoimmune disease, dehydration, malnutrition, all those kinds of things, drug abuse, the poverty, all those things that preclude them for having a healthy immune system to be able to fight this. Okay, so prophylactically, okay, or actually an immunization that they do have for TB is called the Bacille-Calmette-Guerin vaccine, and it's B-A-C-I-L-L-E. Calmette is C-A-L-M-E-T-T-E, and Guerin is G-U-E-R-R-I-N, and call it the BCG vaccine. Okay, and excuse me, it is given to populations in certain countries where TB is rampant. Okay, so they just inoculate the whole population. Okay, what that means is when they come to America and they're screened, their TB test is going to pop positive. Okay, and that's because they have the antibodies. Okay, so from then on, instead of getting a positive TB test, they're going to be asked to see a doctor every year and fill out a questionnaire about coughing and chest pain and shortness of breath and stuff, kind of like we do for COVID, okay? And get a chest x-ray to make sure there's no active disease. And that's going to be the same with you. You can be exposed as a nurse and pop positive, okay? And then you will go to a doctor, answer the questionnaire, you know, and have a chest x-ray to see if you have an active disease. And they will give you the option of going on one of the first drug lines of choice, which is isoniazid. And I'll put that up in chat in just a minute, okay? So anyway, as well as people emigrating to the United States, anybody who cannot take isoniazid, okay, be it pregnant women or whatever that have been exposed, may be able to receive or will be able to have the choice to have the BCG vaccine, okay? So that's a good thing. So how do we assess when that somebody may have tuberculosis or has been exposed? I just said it.
The skin test. Oh my God.
Yes, the MAN2 test, the purified protein derivative test, all of that, the skin test. Now, for those people that have never had a TB skin test before, it's a two-step process, right? You get one week, you wait a week, you get another one another week. Now, who have I talked about in inflammation and stuff may not pop positive for a TB test, even on the second try.
Immune suppressed.
Okay, especially HIV and AIDS patients that have low T cell counts that cannot mediate that cellular defense. And when they look at that skin test, what are they going to measure?
Induration.
There you go. And they're going to, negative would be less than 5 millimeters. Okay. Sometimes there's no bleb at all, you know. So induration, and it's read in how many days?
2.
Yeah, 2 to 3. There you go. Remember my little 2? Everything's 2 in nursing. Okay. So, and then what other kind of test is there besides a skin test?
A blood test.
The blood
X-ray?
test. Well, blood test, the quantiferin gold. Okay, quantiferin gold. So it's either going to be positive or negative. So we talked about the assessment manifestations, and so now we're going to talk about the meds. Okay, so the first one, isoniazid, okay? Number one, all of these meds that I'm putting up here are hepatotoxic. Means what?
They cause liver damage.
Okay, could possibly cause liver damage. Okay, so we want to monitor those liver function tests that I talked about yesterday. Okay, for all of these drugs. Okay. Isoniazid, you're going to have them take it on an empty stomach. If they're taking a pill, if they're in the hospital, you're probably hanging IV piggyback. But a pill, empty stomach. You're also probably going to be giving them B6 because isoniazid depletes B6. So that may be another blood test that they will have to go through besides the liver function and then also a CBC, because one of the other side effects is it can cause agranulocytosis, which means a decrease in all blood counts: white blood cells, red blood cells, platelets. So that means what? They're at risk for other infections, right? Low white blood cells. What's low red blood cells? Low H&H.
Anemia.
Anemia, and then low platelets.
Increased clotting time.
No, but yeah, so they're at risk for bleeding. Absolutely. Okay, so you need to watch for all of that. Also, you need to monitor for peripheral neuropathy. Okay, neuropathy meaning what? Neuro, right? Pathological pathy. So something wrong peripherally. Okay.
Red blood vessels.
So, but neuro. So what would neuro be?
Like tremors.
Sensation, movement. Okay. So sensation. Sometimes they'll feel pins and needles. Sometimes they'll have the nerve pain. You know, sometimes, you know, they just can't feel at all. They can move, but sometimes they don't even feel like they can wiggle their toe because they can't feel that it's there, or their finger. Okay, so that's peripheral neuropathy, and that can happen with isoniazid as well. The next,
Doesn't the B6 actually prevent or reduce the peripheral neuropathy?
yes, these are side effects that can happen. They don't necessarily do happen, because otherwise nobody would ever take these drugs, you know? So, you know, these are things as a nurse we need to look out for. Okay, so rifampin is the next one, rifaximin. Okay, with that one, you also monitor the CBC, the liver function, but you also monitor renal function with that. BUN, creatinine, glomerular filtration rate. Okay. You also take that on an empty stomach, or it can be hung IV piggyback. And the body fluids can become a red-orange color. And I'm talking all body fluids. We're talking sweat, tears, you know, the urine, feces may have a little bit of the water content, maybe that color. So you need to just monitor that closely. Tell them that that's not bleeding, that's, you know, normal for the rifampin. Okay. Next one is ethambutol. Okay. And so ethambutol, again, liver and renal function tests. You also want to do thorough neuro exams on them with ethambutol. Okay, you give it with meals. And also, they need frequent eye exams because they are subject to optic neuritis, inflammation of the optic nerve.
You said optic, what, excuse me, I'm sorry?
Optic neuritis, N-E-U-R-I-T-I-S, itis.
Inflammation. Thank you.
Mm-hmm. Okay. The next one is pyrazinamide. Along with the liver function test, they need a uric acid test because they can develop symptoms of gout. Okay? It's taken with meals as well, or IV piggyback. You know, if they've got nausea and vomiting and they can't take all these pills, then, you know, it's given IV. Okay, so the general regimen is 6 months on these meds. And I'm going to tell you how it works. If it is, if the treatment is progressing, but they are not progressing, they may add, okay, a quinolone and streptomycin. Okay, so it's flexible with that to be able to get them on the mend. But the first four, the isoniazid, the rifampin, the ethambutol, and the pyrazinamide. So for all of those, they're going to need liver function tests, renal function tests, CBC, B6 levels, uric acid levels, okay, on a regular occurrence. Okay. For the first, again, it's a 6-month regimen unless they need to go further. You know, those that are immunocompromised and HIV and AIDS might have to go 10 months, whatever, could be a year. Okay, so out of those first four, all four are taken. The isoniazid, rifampin, the ethambutol, and pyrazinamide, all four of those are taken for 2 months. After 2 months, they drop off the ethambutol and they drop off the pyrazinamide. And they're only on the isoniazid and rifampin for the remainder 4 months.
Can you repeat that one more time?
Absolutely. They are on all four of those drugs, isoniazid, rifampin, ethambutol, and pyrazinamide, okay, for 2 months of the 6-month treatment. After 2 months, they take them off the ethambutol and the pyrazinamide if they are progressing as they should be, and leave them on the isoniazid and rifampin for the remainder 4 months. Now, of course, if they're not progressing as they should, they may add a quinolone such as amikacin, kanamycin, one of those, or aminoglycoside or streptomycin. Okay, and if they're adding streptomycin or one of those mycins, what else do we have to add? Ethambutol, they're going to need vision tests periodically. What about streptomycin?
Hearing.
Hearing, it's ototoxic. So they're going to need a baseline hearing test and hearing test periodically as well. Okay, so the big thing with this is knowing about the disease and how it's spread and how the disease process and how the treatment is going to work. You know, we need to get them in touch with resources because these drugs are expensive. We need to have them with a caseworker or somebody that's going to track them and help them keep on track for all of their doctor's appointments, either hearing, vision, regular doctor, laboratory testing, whatever, because that's a lot to try and coordinate, especially when you're not feeling well, you know, that you need to do for 6 whole months. as you can see, that's why compliance tends to wane a little bit. Plus the fact, if you're dealing with the homeless population and you're dealing with that, there are public health nurses that have to go out and try and find these people to see where they are, maybe deliver their meds and see if they're taking them and how they're doing. Okay, so basically we need to teach them the importance of hand hygiene, which nowadays shouldn't be too difficult, but we want to make sure they're doing proper hand washing or using hand sanitizer. We want to make sure that they're coughing or expectorating into a tissue, you know, into their sleeve, hopefully not expectorating into their sleeve, but into tissue, and discarding it in the proper disposal bag. So all you have to do is close the bag up, put it in the regular garbage bag, and give them another fresh bag to put their tissues in, and a whole nother box of Kleenex, okay? And then, you know, they're going to be used to wearing a mask. You know, nowadays it is what it is. So they're going to get used to wearing a mask. Before, we used to have trouble, but nowadays it's not. And you sure don't want TB complicated by COVID or vice versa. Okay, anybody have any questions on TB?
I do. So for the actual 5 things about tuberculosis that we need to know, is it just like the
You need to know everything I said.
I know that, Miss Lee, but I'm just saying,
Okay.
like the 5 things listed.
Isoniazid, the rifampin, the ethambutol, the pyrazinamide, or the quinolone, and the streptomycin. Whatever I said you had to know.
I think she's referring to the ticket to
As
class.
far as the screen that you have up.
Oh, these are the
Yes,
5
ma'am.
things that you need, you put down.
Like signs and symptoms.
Yes, that we talked about. So if what you put down before class, see to be done before class, and they're
Right.
all correct, then you're good.
Okay.
So, and you just added to it with what I said. You know,
Okay.
it just because we went just through this, okay? And then I just took TB first because it tends to take the longest. And then when we come back from our break, we're going to do cellulitis and we're going to do UTI.
Okay.
I have a question.
Yes.
What questions would you ask the patient when you're doing an assessment? What would be some like things that you would ask them about what's going on? Just like how they're feeling, like what have they been having? Are there any specific
You mean
questions?
when they initially come in, or
Yeah.
well, yeah, what, you know, what have they been experiencing? What brought them into the hospital? You
I
know,
wasn't sure if there's anything specific that you would ask for somebody.
well,
No.
if they, you know, if they're saying, I just don't feel well, blah, 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 you know, they may say, I'm sweating at night. Well, thank God nowadays we wear regular masks because, you know, you're like, okay, adding things off. I have a cough, you know, they may cough into something, or, you know, blood's coming out. Well, you know, okay.
Okay.
So we
Thank
put
you.
them in the ER, in whatever treatment room you need to do for TB, COVID, whatever. I don't know how they function it. And one of the other things we need to teach, whatever we teach them, we need to reinforce. And also provide referrals for alcohol, you know, Alcoholics Anonymous, Narcotics Anonymous, smoking cessation, low-cost clinics, counseling, and those kinds of things, because it's difficult to disease to put up with for 6 months. And some people are doing that with COVID, you know, the peripheral pain, taste and smell and all of that. So just so you know. All right, go ahead. I'll give you till about, what, 26, 27 minutes of 12. And then, yeah. And then we'll take care of these puppies with cellulitis and UTI. Okay?
So what time are we coming back?
About 26 minutes of, I was going to say, you know what, make it 11:40.
Okay, thank you.
11:40.
Thank you.
Welcome. I'm putting it in chat.
Miss Lee,
Yes.
what did you say about the last drugs, the streptomycin and the Q word? Because I didn't really hear you say
Okay,
anything about them, or did you not?
The streptomycin is ototoxic.
Okay, okay.
So they need periodic hearing tests.
For those,
Okay, thank you.
For those two drugs, would those be added on to the isoniazid and the rifampin?
Yes,
Okay.
yes.
So you wouldn't continue with the other two ones?
It depends on the physician and what they're treating. If the culture comes back and it's a multi-drug resistant organism, they may keep them on those 4 anti-tubercular drugs and add those other antibiotics as well.
Okay, thank you.
Welcome. Okay, so it's 11:40. So just to recap, okay, for TB, you're going to treat their symptoms. You're going to give them their anti-tubercular meds. You're going to monitor those labs and those do assessments to monitor for those side effects from those medications, those anti-tubercular drugs. You're going to give them antipyretics as needed for the fevers. You're going to give them analgesics as needed for pain. It could be low dose opioid. It could be NSAID. It depends on the physician and the type of pain they're having. It could be, a number of things. We're going to be giving them respiratory support as dictated per symptoms, O2, that kind of thing. Sometimes patients don't wish to put stuff in a tissue or whatever. I've seen them with, if you've ever seen a Yankauer suction, which is the one that just goes right in the mouth up to wall suction, and they'll keep it like in their bed. So be careful when you're handling, always use gloves and stuff, but they'll cough something up and put it by their mouth and have it sucked into the canister, as opposed to all these dirty Kleenexes and things like that. So I just want you to be aware, and they may ask for something of that nature. Okay.
Are you still talking about
I said recap for TB.
Okay, awesome.
Okay.
Be any dietary or lifestyle interventions or therapies that you would do for them outside of pharmacological?
Oh yeah, well, I mean, if they're malnourished, what do you need, just like with any of the inflammatory processes that we've talked before, just with healing in general, they need high calorie, they need high protein, they need, smaller meals are going to be better for them to ingest, especially if they're having respiratory difficulty. They may even, don't expect them to chew a lot if they're struggling to breathe. And an Ensure supplement or a liquid supplement might be better for them to keep up with the nutrition. But it depends on what comorbidities they have as well. So if they also have cirrhosis, or they're, in liver failure, and they've got TB, and, they're on these meds, or they're trying to put them on other meds, but, they're really in liver failure from alcoholism. Okay. You really need to then, watch their protein intake, because then the ammonia is going up, and you're going to have a drop in level of consciousness if they get too much protein. So, that's when you collaborate with the dietitian and the nutritionist to make sure what's optimal nutrition for them, with possible supplements and things, and incorporating foods that they normally eat at home and not strange things. So, and beans are a wonderful source of protein, when you combine them, red beans and rice is awesome, or any kind of black beans, just beans in general. Great source of protein, low in fat, that kind of thing. Plus it kind of, gives you something, gives you your fiber, all that kind of good stuff. But yes, all those general interventions that we talked about yesterday, those kinds of concepts, as your patient needs them, that's when you're going to bring them forward. You're going to have them on INO, especially if you're looking at renal. So just be sure, I'm not, just because I'm not saying that you're going to do yada, 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 that we talked about before, in every disease process doesn't mean it doesn't apply. That's why I said general interventions. You're going to take vital signs on all of them, depending on the inflammatory process and the disease process is going to depend on which vital sign you hone in on. So for TB, it's probably going to be respiratory rate, it's going to be O2 set, and it's going to be temperature. You might see the heart rate come up a little bit too, but the blood pressure shouldn't be affected unless they're dehydrated. You know, so you have to think through what's going on with my patient. What is the question asking in clinical? How is this presenting? How does it relate? Is this something new? Is this something I'm already treating? What's the priority? Okay. All right. So talking about cellulitis, okay. It's an acute bacterial infection of the dermis and underlying connective tissue. You know, it starts out as inflammation, and it can start out as something as insignificant as a bug bite. But depending on, you know, patients' risk factors and things like that, and their propensity to pick at things, sometimes it can seriously get into a wound and have a bacterial infection. How do we know when inflammation has gone into infection? What did we say?
Increased white blood cells.
Yep.
Fever,
Fever,
exudate,
yeah.
purulent exudate.
There you go. Malaise, those all hallmark kind of I don't feel good symptoms. Okay. And so another one that's specific to cellulitis, it'll start getting a red or a dark red to lilac appearance around the wound, or sometimes if it doesn't have a wound, it'll be in an area, which means it's underneath the skin and the top just maybe hasn't sloughed off yet. That's not a good sign. But and I'm not talking about a bruise. I'm talking about, you know, a wound, okay? And you know, an area that you can see is fragile and that skin's just gonna kind of slough off. So you want to take note of that area, and that is the only time you are allowed to write on your patient. Okay, you circle that area, you put your initials, the date and the time, and you watch that area all through the day. Okay, hopefully, depending on if it's a new admit, they may go a little bit outside the circle because they haven't had, you know, 24 hours of IV piggyback, IV antibiotics yet to help start acting on this. But if you're a couple days into it, it should be coming into the circle. Every day you have that patient, you should be able to draw another circle, and it's within the one from the day before. It should get better and better and better. Okay. So what are the bacteria that mainly stay on the skin?
Strep.
Okay,
No,
strep
so
A.
staph would be on the skin, strep would be in your throat.
No, strep is pathologic. Okay, but you're getting somewhere. Hang on.
Is it
Staph
staph?
aureus is on the skin, and so is group A strep on the skin. Okay, when it gets into places like the throat, it gets to be pathological. Okay, so same thing when you have a break in the skin, as long as it's on top of the skin, it's doing its job in protecting the skin. You have a break in the skin and the staph gets in the skin, or the strep gets underneath in the underlying tissues, that's when it becomes pathological and starts creating wounds. Does that make sense? Okay. So, and of course, the strep has morphed into, can be flesh eating or necrotizing fasciitis. Those are things that are just, you know, not fun to deal with. But who's at risk for cellulitis?
Diabetes patient.
Okay, why is somebody with diabetes mellitus at risk?
Peripheral neuropathy?
There you go. Decreased sensation and circulation, okay? Can take abrasions and little burns and create stasis ulcers and make them and get them very infected. I'll give you an example. Girlfriend and I used to have like movie days together where she'd come over and we get in our get all comfortable and pop popcorn and stuff like that, and she'd take off her shoes. And one day we were walking to the kitchen and I'm hearing tick, tick, tick. And I'm looking behind and the puppies aren't anywhere to be found. And I'm like, what is that sound? And Vicky was like, huh, what? You know, I don't know. And then we continue walking, it's tick, 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 tick. And I'm like, okay, did you hear that? Yeah, I heard that. And so I'm like, it almost sounds like when we're walking. So I'm looking at my feet and stuff. And I said, I'm not feeling any pain. Vicky's like, me neither. And I said, Vicky, have you checked your feet? And she says, yeah, look. And she's got her toes there. And I said, I mean, the bottom, baby. You need to check the bottom of your feet and in between your toes as well. And she's like, why would I do that? Well, she's a big one for going barefoot out in her backyard and everywhere. She had a roofing tack stuck in her foot and did not know it and did not feel it. And it was red and excoriated around it, and the tack was still there. That's what was ticking. So instead of having a movie day with my friend, we had an urgent care day with my friend. And she ended up, you know, having to go to the wound clinic and stuff like that for several weeks after that to make sure she didn't develop osteomyelitis, which is a complication of cellulitis. And it is a bone infection.
Does she have diabetes?
Yes.
Okay, that's fine.
Sorry. Yes. I negated to say that. But then again, I don't have diabetes, but I have disc problems. And so I don't feel my toes when I go and get a pedicure and stuff. I don't know if it's too hot unless I put my toes in it and they turn instantly red, then I know it's too hot. And then, you know, you just go, but I check my feet all the time. So those with diabetes, those that are obese, okay, and are sedentary, decreased physical mobility, okay, if they're malnourished or dehydrated in any way. So white blood cells take protein to be able to be manufactured in the body. So if they have, you know, very low total protein and albumin in their system, it's an indication that they don't have enough protein to help with that, help with the mediation of those white blood cells for the immune response. So those with an immune weakened system as well, those with PVD, okay, they don't have circulation there. And so again, they can start getting black toes from lack of circulation, okay, because it's not getting all the way down, or stasis ulcers. And then because it cracks and does that kind of thing, bacteria will invade and then cause an infection. Okay.
Miss Leaf?
Yes.
So is staph and strep responsible for cellulitis, or was it one or the other? Or
both. It depends. Yeah, it could be one or the other. It could be something totally different, you know, but those are the major organisms that we see. And then they could be resistant too. You got methicillin resistant Staph aureus out there, which we used to treat with vancomycin, and then it got smart and we ended up with VRSA, which is vancomycin resistant Staph aureus. You know, there's vancomycin resistant Enterococcus and all those different kinds of things. And I can go on and on and on with the initials. But the big thing is when you get a patient with cellulitis, number one, you're going to look at the CBC. You know, they may order a sed rate, but they're definitely going to look at a CBC to see how high the white blood cell count is. And then they may ask you to do a wound culture. Now, if you have a patient that comes up from the ER and the wound dressing is saturated, okay, how are you going to get that culture? What are you going to do?
Use the
Go into the part that's where you have to go into the wound, like.
Okay, so actually what you may do is take off that, and if there's that purulent drainage and stuff covering that wound area, you can take a sterile 4x4 with some sterile normal saline or some water and just gently wipe away that purulent drainage. That purulent drainage is not the active bacteria. That is the residue of dead skin cells and waste products and white blood cells and other things from the bacteria. Okay, the bacteria is still embedded into the tissue that is going to make more of that as time goes on, unless we catch it and the antibiotics kill the bacteria. So you need to go, pardon the expression, in the meat of, don't dig in there, but I mean, take, a swab of the pinky skin or the reddish skin that you see, and then send that for a culture. And then you start the antibiotic afterwards. Okay, whenever you do a culture, you always do that first, and then unless they're already on antibiotics, then it doesn't matter. You do the culture because they think that there's something else in there other than what they're treating it for. Okay, so wound culture and then sensitivity. Now let me tell you about culture and sensitivity, and this goes for UTI as well. Once you send in the culture, it's going to grow something. Okay, it's going to grow a bacteria or yeast or something. And then it's going to give you what that bacteria or yeast or whatever is sensitive to, and going to give you a list of antibiotics. If it has an R next to that antibiotic, that means that it's resistant. So that antibiotic is not going to work on that bacteria because that bacteria is resistant to that medication. If you have an equal sign, that means that it's not really going to do any good. It's not resistant, but it's not really susceptible either. It's like you're using a garden hose to put out a house fire instead of a fire hose kind of thing. Like it's not going to nip it in the bud like you want it to. And yet if it has SS before the antibiotic, that means that that bacteria is susceptible to that antibiotic and will kill it. That's the one you want. Okay, so that's how you read a culture and sensitivity. Okay, so as we look at our patient and they have this wound and we've outlined it, they're probably, if it's on an outpatient basis and we're in a clinic, we're going to tell them to do most moist wound care, take their oral antibiotics. It's usually going to be at least a 10-day treatment. We're going to tell them to what? To the extremity.
Elevate.
Elevate. Elevate. Maybe not move it so much or be up. Okay, so if it's on a leg and they sit in a dependent position, that's not elevation, right? We got to tell them to put their leg up on something so that's elevated. If they're in a hospital bed, we can prop it up on a pillow or two, as long as they don't have a heart thing. We're not raising it above the heart to increase the preload, okay? We're just elevating it so that it doesn't increase in edema. When it increases in edema, it increases in pain. And we also want to keep them comfortable. So we will be giving them some sort of analgesia, especially if when we do the wound care, it is painful, that you medicate them prior to that, okay? So, and that would be at home as well. Tell them to take their pain medicine before they do their, family member or they do the wound care on themselves. We need to teach them good hygiene when they go home. And nowadays, everybody's mindful of that. But we need to also tell them it when they're changing their dressing, we know it's their stuff and it's them, but they need to wash their hands and put on gloves. Okay? Change the dressing, do whatever they need to do with their dressing with clean technique that they have been shown before, and then put the clean dressing on and dispose of the gloves and wash their hands. Okay, very important. They have to use gloves. Otherwise, they're going to be touching all kinds of stuff with their hands and contaminating all kinds of stuff. Who doesn't know about contamination nowadays, right? With COVID, staying on everything. So we want to rest it. We want to elevate it, maybe put some warm compresses on the affected area. We want to teach them good infection control. We want to have them comply with the treatment regimens and taking the entire dose of medicine. Not, I feel better, it looks better, I'm going to save this for the next time I have this. Because the next time that medication won't work, and they may, if they were outpatient, they may end up in the hospital because they need something stronger. But what else are we going to teach them? Signs and symptoms of when
It's getting worse.
yes, and they need to call the doctor or they need to go to the hospital. Okay, so if the fever goes above 101, they have shaking chills, if the lethargy gets worse, if the area gets bigger, all those kinds of things. If the inflammation in the area and the infection gets worse, they need to call their healthcare provider or go to the emergency room.
And if it gets
Okay.
darker in the center, right?
Yeah, I mean, but with that, you'll see it spread out as well. Like the reddened area and the, you know, everything will get larger, pain will get worse. The heat, you know, it'll be hot on most of the leg. You know, maybe they could stand on it before, now they can barely touch to walk on it, you know, those kinds of things. So very specific to that patient. Okay. So again, you know, untreated, it can lead to osteomyelitis. It can lead to sepsis, like I was talking about. All right. So, all right. So UTIs. Okay. How do we keep from getting a catheter associated urinary tract infection for our patients?
Move as fast as possible and follow sterile technique when inserting.
There you go.
DC as soon as possible.
Yes, absolutely. So criteria has to be met. I mean, you know, if you know, you're like, oh well, they have a Foley. You know, I need to DC this urinary catheter. If they've got a sacral decubitus, or if they've got you know, decubitus on their trochanters or whatever, that may not be the best thing because they could be sitting in moisture. You could check them 1 hour and the following hour them be wet, and they've been sitting in that moisture and all that kind of bacteria has been, you know, congregating on that urine, and maybe something else will get into that wound. Okay, so that may be a criteria that tells you to leave that in. But then you have to maintain, and I can't say this enough, just meticulous perineal care. And I'm talking about when you wash the patient, you know, especially women who are very susceptible to UTIs because they have a shorter urethra and it's closer to the anus, okay, that, and especially if they're incontinent of feces, you need to clean that at least really good with soap and water or with whatever they're cleaning once a day, and then PRN as it gets soiled. You can't just hurry up and just kind of wipe it and stuff. You got to make sure there's no residue left. You also have to make sure that that catheter has some give in it, but is secured to the upper thigh or lower abdomen for males, okay? So it doesn't constantly pull on the meatus between the urethra and the bladder, okay? Because that can cause excoriation and inflammation and cause infection as well, okay? And then you always want to keep that GU bag, okay, the urine bag below the area of the bladder. When you turn them over, do not be lazy and have it flop across their leg, because it's going to have to go uphill, and it's not going to go uphill against gravity. You need to move it to the other side below the level of the bladder so that it can flow freely out of the bladder and into the bag. Whatever's in the bag is contaminated, period. You can't get a urinalysis out of there, okay? There's too many times people empty it, they let the little spigot, you know, go around the container. They don't rinse out the container. There's all kind of bacteria in there. Boom, it's up in the bag. Now, what is our normal preventative measure for getting rid of bacteria that comes up into the urethra?
Urinate.
Yes, absolutely. The act of urination flushes that bacteria out of the urethra and keeps it from going up into the bladder. That's why it's so important to get up and urinate every 3 to 4 hours, okay? But when you have a catheter in there, it keeps that meatus open and leads a super highway right up into that bladder for that bacteria to travel. So if that catheter is not clean, if you don't use sterile technique in inserting it, they can end up with a UTI, okay? Another thing, when you're getting a urinalysis sample, okay, if they don't have a catheter, then how are you going to get it?
Free catch.
Okay, clean catch. Clean catch is what? How do you do it?
You
Or how
let
do you
them
tell the patient
urinate
do
a
it?
little bit. You let them urinate a little bit, and then they start to catch it after some's expelled.
Okay, but first of all, they have to clean with some kind of wipes, some kind of antiseptic wipes. And you can't just give them one. You got to give them more than one, okay? So they can clean around the area and then down the middle. And then they urinate a little bit to flush that bacteria out of the urethra. And then they put the cup there and urinate into the cup. For the men, it's the same thing. Clean the meatus, you pee a little bit, and then into the cup so that you can clean out that urethra. If they go right into the cup, all that bacteria that has traveled up into the urethra goes into the cup, and it's a contaminated sample because it may not be the bacteria that's actually causing the problems that's sitting up in the bladder. Okay, so
Also, if they're unable to, you can use a quick gas.
you can use an in and out cath, very good. But again, sterile technique is very, very important there. Also, if they already have an indwelling urinary catheter, there's a port right up there by where you would have used the syringe to fill up the balloon. There's a port there, and you will clean and clean and clean that with alcohol wipes, okay? And then of course, you'll have gloves and everything, and you will take it depends if needleless device or with the needle, and you will insert it. Now, into the port and draw up 5 to 10 milliliters. Now, I will tell you, if there is urine already there, are you going to use it?
No,
Why not?
it might be contaminated.
Well, you don't know how long it's been sitting there. Absolutely. Is it truly, if it's cool to touch or barely warm, then you know it hadn't come from the bladder. So you need to drain the urine that's there, drain it completely and empty the bladder as much as you can, okay, into the GU, that urine into the GU bag, and then rubber band the tubing or clamp it in such a way up towards the patient where, it's not very, very far, but you give them a couple minutes, maybe, go around, clean their room, change their trash, whatever you need to do for their environment, keep it clean, get them comfortable, come back and look, and then that tube should have some urine in it. It should be nice and warm because it's coming right from the bladder. It's a fresh sample, and then you can aspirate it, put it in the cup, and send it off. Does that make sense to you? Okay, what you're going to do is also then look at that urine. Okay, if it's cloudy, if it's got an odor, right? What color is it? Is it dark? Is it clear yellow? What's going on with the urine? If it's dark, if it's cloudy and has sediment and stuff, you can more than likely bet that there's something going on with that urine. Okay, and how are you going to know? A lot of times before they get a culture and they send it for culture and sensitivity, they're going to do a what?
Dipstick? I don't know what you call
Well, they'll do a urinalysis.
Yeah.
Okay, they're going to come back with the color and the turbidity, or if it's clear or cloudy, and then they're going to come back with a pH. Okay, the pH, you know what that is?
Yes,
Okay.
it should be slightly acidic for females and slightly alkalytic for males.
No, acidic for
No.
both. Acidic
Oh,
for
acidic.
both.
Okay.
So,
7.4. 7.4.
yeah, acidic for both. Males will usually have UTIs when what? What did y'all learn about?
When they have BPH,
Yes. And they have stasis of urine in the bladder because they can't urinate it all out at one time and with a forceful stream. Okay. So it'll work its way up into the bladder, even though the urethra is longer, but then by that, so they can have UTIs as well. Don't just blow it off as their BPH, make sure, because if they're elderly or whatever, they're not going to have the sensation of pain and stuff like a normal adult. So, make sure you're looking at that urine and looking at the color and if it's cloudy and all those kinds of things. If it is normal urine and it's yellow and it's clear and it's within that pH range, and you can look it up and it's on your lab sheet, I believe. Okay. Everything else should be negative. No red blood cells, no white blood cells. A normal urinalysis does not have glucose, does not have ketones, does not have leukocyte esterase. Okay, all that is negative. When you start seeing problems, is going to be the pH could be normal, within that normal range or on the high side, but you're going to see leukocyte esterase, which comes from white blood cells. You can see, they'll put the number of white blood cells when they do a microscopic, or they'll put few or some or many. They'll put the number of red blood cells on there. Again, few, some, or many, and then when they do a microscopic, how many they see per millimeter or whatever. Okay, and then they'll also put if they see any bacteria or if there's bacteria present, and then it'll say, satisfactory to culture or whatever, and then they'll culture it. Okay, or they might even be able to tell you from the microscopic slide that they see budding yeast, which means there's a yeast factor in there. Is that the only thing that's given a UTI, or is there, you know, a bacterial presence as well, and the yeast just became opportunistic? Does that make sense?
Mm-hmm.
Okay, so for the UTI, okay, again, elderly, their way of, the first time you notice that they have a UTI may be that what? Change in level of consciousness, okay? They may not run a fever per se, but their temperature would be elevated. You know, you wouldn't know until you felt them and say, wow, they feel warm. Now, they don't drink like we're supposed to drink for hydration, because that thirst center is dulled, right? So they're going to be dehydrated, which then also causes a problem and makes them susceptible to a UTI. Okay, and then if they're immunocompromised, they don't eat enough protein, their diet isn't the best. Those kinds of things all play into this. Okay, so basically, what are your classic symptoms of UTIs for a normal adult?
Pain with your
Diuresis.
Okay, so dysuria, so painful and difficulty urinating. Okay, what else?
The urge, the frequent urge to go.
Yes, frequency and urgency. Need to go, need to go, need to go, you know, and you have to go like many times, but a lot of times when you go and you feel like you have to go and it's only a couple drops and it burns like heck. Okay, all right, so nocturia, right? So going 2 or more times during the night. For some elderly, that's not abnormal, you know, so you have to watch. If there's an odor to it, especially smell-felling. I've been talking a lot these past couple of days. Foul-smelling urine, okay? If it's cloudy, if it's blood-tinged or really dark, which can be dehydration and or blood tinged, you know, okay? If they're running a fever, if they have nausea, you know, and some vomiting, or for the elderly, they may just have a loss of appetite, not feeling right, and they may even be hypothermic. For the elderly, this is the biggest way they get septic, is urosepsis.
Ms. Leaf, can protein in the urine cause a UTI?
No, not protein. That's something else.
Okay.
Also, mental status with UTI.
I'm sorry?
Hallucination. With UTIs in the elderly, is it not infrequent to see altered mental status such as hallucinations?
Yes,
delusions?
yes. That's part of the infectious process, that altered level of consciousness, confusion, those kinds of things that, you know, grandma or papa or somebody is just not acting the way they usually do. They don't remember me, you know, like they usually do. All those kinds of things, you should immediately be on the lookout and assessing. You know, if one point in the morning this person's talking, they're lucid, they know who they are, where they are, and stuff like that, you go in 2 hours later and they don't know who the heck you are, and they think you're their niece and this and that, there's something going on. You need to do a thorough assessment, okay?
You know, Grandma had a UTI last week, and she was yelling at the kids that were running around the house when it was just me, her, and my mom in the house.
Wow.
She was getting real agitated.
Yes.
Because all these quote unquote dang kids running around my house being so loud. I'm like, Grandma, there's no one here.
That's it. Well, that's when you get on the phone with the healthcare provider and say something's going on. Okay, so you're going to be doing your vital signs. You're going to be doing your GU assessment, you know, palpating the bladder to see if they're emptying it completely. they're gonna, you know, obviously put them on antibiotics, okay? If it's uncomplicated, it's the first UTI, they're not elderly, they're just normal adult, it's a 3-day course of antibiotics. And let me put it up here because this is what, oh shoot. That was me. Trimethoprim, sulfasalazole, or what is it? TMP SMZ. It should read trimethoprim sulfamethoxazole TMP SMZ is. Now, what do you hear in there?
Miss Leafy, could you, it disappears and because you're sharing your screen, we can't get it back.
What, the chat?
Yeah. Oh, wait, I got it. I'm sorry. My apologies.
Sulfa
Okay.
drug. There's a sulfa drug, so look for sulfa allergies.
Yes, absolutely. And so if they're allergic to sulfa, they'll probably put them on Cipro, but they'll wait, you know, I mean, they'll put them on that and then see what the culture comes back at is, you know, if they have to add antibiotics or, you know, is it something, you know, that's going to be uncomplicated, that's fine. So it's 3 days, maybe 5 days, but then you have the more complicated that's 10 to 14 days treatment, and it's usually IV antibiotics, and it can, you know, more than likely be a multi-drug resistant organism. Okay, but the goal is to remove that catheter as soon as, if they've got sphincter control and they don't have any wounds or anything, and you can put them on a bedpan or the PureWick, or you can, you know, even if they're incontinent, you know, checking them every hour between the nursing assistant and the nurse to be able to change them. It's better than a UTI because they have that normal flushing mechanism to flush that bacteria out. Okay, but if they have, you know, need for a catheter for something else, you have to have meticulous care, at least one time a shift for perineal care and, you know, catheter care, cleaning it real good, and then PRN any soiling. So the antibiotic treatment, also analgesics for pain. One of them is going to be pyridium, and I put the wrong thing up this morning. I misspelled it. It is, so I'll put this up as the recording when I put it up. Oh, come on. My fingers don't want to work either. Okay. So it's phenoxyperoxide, pyridine. Oh, sorry, pyridine. I put that wrong. Still, see? So PYRIDINE
What is that?
HCl. Pyridium. Okay, so just that's phenazopyridine hydrochloride or pyridium is how I know it. and it is an internal analgesic. It'll turn the urine red-orange, and it also acts as an internal analgesic that kind of deadens or numbs the urethra, so that you're not sitting there going, I don't want to pee, I don't want to pee, it hurts so bad, it hurts so bad. The pyridium makes it easier. You don't feel it, and you can just urinate like you're supposed to, and every 3 to 4 hours. Okay, you have to. You know, based on these, based on the types of organisms that infiltrate the UTIs and cellulitis, they could be on contact isolation as well. Okay, especially multi-drug resistant organisms. Okay, so prevention of UTIs. Okay, fluid intake of 2 to 3 liters per day. That's when you go in and tell these little old men and little old ladies to drink. Okay, provided they're not on a fluid restriction, but even then, they're probably not drinking all they're supposed to be. Okay, you want to make sure they're putting out 30 milliliters, okay, an hour of urine. And you want to make sure it's turning clear, it's getting better, and not getting worse. You want them to be able to empty their bladder every 3 to 4 times a day. If they have family members that are with them, make sure they get them up and go to the bathroom. Little old ladies like to put pads in their underwear so that, you know, when they cough, sneeze, or laugh too hard, if they dribble, it's there. But those pads cost money, and they'll sit in those pads too for a length of time, and you can almost smell that old urine smell. Okay, and that means that bacteria has already infiltrated that. So we need to make sure they're changing those on a regular basis, and that they're getting up and going to empty their bladder every 3 to 4 hours. Women needs to clean their perineal from front to back because of the close proximity of the opening to the anus, and then void and wash their perineal area before and after intercourse, so they don't get honeymoon cystitis. You want to maintain the integrity of the perineal tissues. Avoid bubble baths, those foaming balls, the feminine sprays, douches, all that kind of stuff. If it makes you itch when you get out, if it burns, you're uncomfortable down there, then it's telling you not to use it. Okay, that it's doing, because it can dry out your perineum. When it dries out your perineum down there, you get what happens when your skin dries out.
Starts to flake.
Or you get cracks, right? And so when that happens, there's an opening for bacteria to invade. Okay, so also we need to keep the urine acidic. So, they are not supposed to drink copious amounts, which is just a lot of orange juice or cranberry juice. Has a lot of sugar in it, it's gonna make it worse, not better. Okay, they can drink a 8-ounce glass of unsweetened cranberry juice, or who really wants to do that? It makes me pucker just thinking about it. But cranberry capsules are good because it's just as effective. Vitamin C tablets, just as effective at making the urine acidic for both men and women.
So what about like the AZO cranberry pills?
I don't know what the AZO is. So, cranberry makes it acidic. I would just go with cranberry. When you start adding all that other stuff, it can definitely, complicate the other meds and maybe contraindicate those other meds and cause them not to be as is effective when you start adding some of those other alternative meds. So you have to make sure that if you're on those antibiotics, that you look up at those antibiotics and you see what they're compatible or incompatible with as far as those alternative meds. But the plain cranberry capsules are fine, or vitamin C tablets are fine. Now, vitamin C, because it's a water-soluble vitamin, that's why it's excreted into the urine, okay, won't last that long. So if you have a UTI or you're under stress or you just want to stay healthy, you might want to take it twice a day, if you're taking 1,000 milligrams a day, take 500 in the morning and 500 at night, just to keep a steady pH going there and keep it in your system. Okay, you can't really overdose unless you take a whole bottle, but you tell them more is sometimes more. It's not going to be more effective. Okay. So as long as it's acidic and they're voiding and they're hydrating and they take care of their perineal area, and men take care of your area as well, because you can get from jock itch and stuff, that's your, the yeast producing there, so can get yeast into the bladder. Women, anytime you sweat and keep that area moist and stuff, yeast is an opportunistic infection that will go from there too. So somebody says, what is that replacing? The phenhexopyridine hydrochloride, pyridium, is the correct spelling, and I put phenazopyride. So take the second one after the trimethoprim, sulfamethoxazole. Okay. So that's how the big thing we want to prevent. CAUTIs, again, usually are asymptomatic until, like the elderly, Cole's grandmother ends up hallucinating, or they get confused or whatever, and then it's like, because sometimes you get used to that quote unquote old urine smell and other things, but it needs to be investigated. Okay. All right, that's it, you guys. Good luck on Tuesday. I will post this probably after the test sometime. You're not going to look at it before that. So I appreciate you hanging in there with me. And, I'm here if you need me. The chat is open for the UTI. I don't expect, or the infection. The discussion board, I don't expect I'll see you there until after the test, but y'all take care. Remember my test taking tips and strategies, okay? So take care of yourselves. Bye.
Miss Leaf.
Oh, wait, where's my clinical group? Can you stay on for a minute for tomorrow? Not my 317, my 316.
Oh.
Yeah.
Oh, poop. I heard that. You were not muted for that.
No, I said I don't know which group.
316 is my group.
I know I'm your group.
Wednesday, Thursday.
Okay. Okay, so yeah, I can stay on.
Just for a minute.
Okay, that's fine. But I also had a question.
Okay.
As far as the discussion board,
yes.
Do you answer for all concepts or just the ones you lecture on?
Just the ones I lecture on.
No, Miss.
Yeah, so it's inflammation and infection and eventually comfort. You got to go to the other instructors' discussion boards to have questions answered. Yes.
Okay.
Okay. Diamond, you don't have to stay because this is going to be from my nursing group.
Or your nursing group, not special pop. Okay, that's what I
Right.
was thinking.
Okay.
Okay.
Bye.
Okay, thank
Rochelle, you can sign off. Ariel, you can sign off. Caitlin, you can sign off. Grayson, you can sign off. Tanisha, you can sign off. Yeah, that's a how do you do, huh? You know what, Maja and Danica, since you're the only ones that are here, I'm gonna go ahead and just text you. It's no big deal. It's just about, make sure to bring your stethoscope and everything for tomorrow. And
Okay.
we're going to be doing, similar, we're going to do the blood pressures. We're going to, do the assessments, and we're going to go through all of that stuff. And so, but we are meeting in the gym.
Okay.
Okay?
Okay.
So I'll see you
Okay.
tomorrow
Okay,
at
okay.
7:30. So that's all I wanted to do and I'll text you that. Okay? I don't more.
All right.
I don't want
Okay,
you.
no problem.
Yeah. All right. Bye, you guys.
All right. Bye.